Hello, we will be discussing malignant bone lesions today. Let's begin with the most notorious one, the osteosarcoma. Osteosarcoma, as we all know, is the second most common malignant primary bone tumor. It is the commonest primary malignant bone tumor in young adults and in adolescents. So, guys, what is the most common primary malignant bone tumor? Yes, it is multiple myeloma, right? The most common malignant bone tumor is metastasis. Osteosarcomas are characterized by the production of malignant osteoid, and the tumor matrix is highly variable. It should not always be osteoid tissue, but can involve calcification, fibrous tissue, cartilaginous tissue, or combination of all of these. Okay, first of all, we'll be covering basics of theories, all right? So, talking about the classification of osteosarcomas, this can be intraosseous osteosarcomas within the bone, can be conventional ones, telangiectatic ones, small cell osteosarcomas, low grade ones, or cortical osteosarcomas. Surface osteosarcomas are the ones which arise on the surface of the bones, can be periosteal or parosteal. Extraosseous osteosarcomas. Can osteosarcomas arise outside of bones? Yes, we'll be discussing about this later as well. There can be multicentric osteosarcomas and secondary osteosarcomas. The most common of the osteosarcomas is the conventional or intramedullary osteosarcomas. It occurs in two peak incidences. 10 to 25 years of life is the most common age group because of the rapid bone growth, because of the age of the rapid bone growth. Because it occurs in the sites of rapid bone growth, metaphyseal region is the most common site for osteosarcomas. Nevertheless, high yield point is that osteosarcomas can be also seen in diaphyseal and epiphyseal region. Okay, the most common site, as shown in the image, is the distal femur, followed by proximal tibia, proximal humerus, in skull, and in jaw, in pelvis as well. So whenever you are provided X-ray of young adult around the region of the knee in the metaphyseal region, most probably it is osteosarcoma. Okay. Multifocal osteosarcomas are common, but in less than 10 years of life. They can be synchronous or metachronous. Synchronous ones are the ones that occur within 6 months, and metachronous ones are detected after 6 months of detection of the primary lesion. Risk factors for development of osteosarcomas: rapid bone growth. Number one, the only environmental risk factor that has been proved till age is radiation exposure. High yield radiation exposure can lead to osteosarcomas. And the risk factors for secondary osteosarcomas are Paget's disease, fibrous dysplasia, enchondromatosis, hereditary multiple exostosis, retinoblastomas. Why do retinoblastomas lead to osteosarcomas, guys? Step one question, yes, because of two basic reasons. First of all, if there is mutation of retinoblastoma gene, that's why. Second, because of the treatment of retinoblastoma with radiation, there is high chance of formation of osteosarcomas. As we've discussed, radiation exposure is a risk factor for osteosarcoma. The next one is Lee-Frommeny syndrome. Poor prognostic factors at the time of presentation of osteosarcomas. High yield can be asked in any form in MCQs. High ALP, high LDH, expression of certain kinds of genes like MIR148A. If there is involvement of axial skeletal like jaw or pelvis or skull, secondary osteosarcomas. And this is very high yield. After diagnosis of osteosarcoma, treatment usually involves neoadjuvant chemotherapy. And if after that chemotherapy there is less than 95% tumor necrosis, then that goes in favor of a poor prognostic factor for osteosarcoma. If metastasis or pathologic fractures are present at the time of presentation, or if skip lesions are present, and if soft tissue mass is more than 20 centimeter, all of these are poor prognostic factors. Now, high yield, what are the findings of osteosarcoma in X-ray? There are various kinds of malignant periosteal reactions noted, the first and most common one being the sunburst pattern, where we can see periosteal reaction perpendicular to the surface of the bone, okay? The next one is lamellated pattern, where the periosteal reactions are seen but are seen parallel to the surface of the bone and not on the perpendicular surface of the bone. Codman's triangle. Codman's triangle is formed because of lifting of the periosteum. New bone is formed so rapidly that the periosteum cannot cover the new bone formation. Therefore, there is lifting of the periosteum, giving rise to Codman's triangle. There's cortical disruption, moth-eaten pattern of bone destruction, and transphysial spread before plate closure. This is high yield. Normally, osteosarcomas occur in metaphyseal regions, but they can have transphysial spread, and then they can go to epiphysis and to the joints. Okay, pneumothorax. Do you know the most common cause of death in individuals with osteosarcoma? Yes, it is lung mets. Metastasis to lungs is the most common cause of death in individuals with osteosarcomas. And because the mets are osteoblastic and they are located in subpleural location, there is formation of pneumothorax. Any occult pneumothorax in young people should always be investigated for osteosarcomas. And we can also see skip lesions or metastatic lesions as well. So, this is a typical finding of osteosarcoma. Can you tell me what kind of pattern of periosteal reaction is this? You can see perpendicular periosteal reactions that are perpendicular to the surface of the bone. You got it right. This is sunburst pattern. Here you can appreciate Codman's triangle has been formed. There is lifting of the periosteum. There's fluffy cloud-like osteoid matrix formation. This is Codman's triangle. Here you can appreciate cortical disruption, and there is bone destruction more in the moth-eaten pattern as well in the metaphyseal region, all findings of osteosarcoma. So this is how you characteristically approach a lesion when you suspect it of osteosarcoma. First of all, okay, you've undergone X-ray and you diagnose maybe it is a case of osteosarcoma. Then the next thing to do is to opt for a bone scan to note if there are multiple lesions, polyostotic lesions, skip lesions, okay? Then you go for chest CT. What to look for? Yes, to look for osteoblastic metastasis, to look for pneumothorax. Then you go for MR. MR has multiple advantages over CT or X-ray. It gives us epiphyseal involvement, soft tissue involvement, bone marrow involvement, joint involvement, neurovascular bundle involvement. Then you plan biopsy. Okay, you biopsy it, it comes out as osteosarcoma, then it's final. You go for neoadjuvant chemotherapy, as we discussed earlier as well. Now, after the neoadjuvant chemotherapy, you restage the tumor and rebiopsy. Now, this restaging predicts the outcome. If in the biopsy that has been performed after neoadjuvant chemotherapy, more than 90% of the tumor shows death, necrosis, then it shows a good outcome of this condition, okay? Then you go for surgery, then adjuvant chemotherapy. You should keep on following within 2 years, because most of the cases of recurrences and relapses occur within 2 years. Most common site of relapse is to lung, 80% to lung, 20% to bone. Okay, Next high-yield topic is surface osteosarcomas. Surface osteosarcomas, as we said earlier in classification, can be periosteal ones or parosteal ones. Parosteal ones arise from the outer layer of the periosteum. Periosteal ones arise from the inner layer of the periosteum. So, periosteal, peri arise from inner surface of periosteum. Parosteal arises from outer surface of periosteum. Okay, differences between these two is high yield. Parosteal ones occur in early adults in the metaphyseal region. Most common site is posterior distal femur, posterior part, okay, in the distal femur, but in the posterior part. And because this involve the outer layer of the periosteum, marrow extension is fairly common. But these are low grade, these involve outer layer of periosteum, and we'll see in the image later a string sign is present, which refers to a lucency between the tumor matrix and the surface periosteum. Okay, whereas the periosteal ones are seen in 15 to 25 years of life, most common in diaphyseal region, unlike conventional osteosarcomas, most commonly seen in medial distal femur. Marrow extensions are rare, more high grade compared to parosteal ones, and arise from the inner layer of periosteum. So look at this image. You can see sunburst pattern of a periosteal reaction, right? Perpendicular to the surface of the bone. But what are the things that you can appreciate? You can appreciate lesion in the diaphyseal part of the bone, right? And we can also appreciate that the inner surface of periosteum has also been involved and there's somehow endosteal scalloping. So what do you think? It is parosteal or periosteal? Yes, you got it right. It is periosteal, all right? Whereas here you can see there is a fluffy tumor matrix arising on the surface of the bone. We can appreciate a string sign, which is a lucency between the periosteum and the tumor matrix. This is the string sign. String sign is typical of parosteal osteosarcoma. Now talking about telangiectatic osteosarcoma. Telangiectatic osteosarcoma shows typical fluid level on X-rays or MRs. We see narrow zone of transition on X-ray and how to differentiate it from ABCs or giant cell tumors. We see tumor nodularity and enhancement of the septa. All right. So here in this image, we can appreciate there is aggressive lesion with fluid level on T2 image, which indicates hemorrhage. We can also appreciate peripheral enhancement on gadolinium administration. This is a case of telangiectatic osteosarcoma. And high yield point for core exams is which are the lesions that show fluid levels on X-rays or MRs. These are telangiectatic osteosarcomas, ABCs, and giant cell tumors. All right. Okay. So the prognosis wise, the best prognosis is of PAROSTEAL, followed by PERIOSTEAL, telangiectatic, classic, and the worst prognosis of all is seen in secondary osteosarcomas that arises from patches or fibrous dysplasia, etc. So we discussed earlier as well. Do you think osteosarcomas can be present outside of the bones? Yes, outside of the bones too, osteosarcomas can be present. For example, they can be seen in buttocks, in retroperitoneum, in breast, kidneys, etc. Okay, so it's high yield. Can osteosarcomas occur outside of normal bones? Yes. There's something called reverse joining phenomenon. Do you know what it is? Normally, in osteosarcomas, the most dense part of the matrix is located in the center of the lesion, okay? Whereas the periphery of the lesion is less dense. But in myositis ossificans, which case also there is calcification in the soft tissue, the periphery of the lesion shows high density matrix, whereas the center of the lesion will be low density matrix. So this is called reverse zoning phenomenon, and it helps in differentiating between the soft tissue calcification of myositis ossificans and that of osteosarcoma. Do you know what mathic osteosarcoma is? Mathic osteosarcoma refers to the osteosarcoma of jaw. It is most commonly seen in young individuals and has a poor prognosis. Okay, next on we'll be discussing about Ewing's sarcoma, which is the second most common primary bone malignancy in children after osteosarcoma. It belongs to the family of small round blue cell tumors. Which of the other small round blue cell tumors do you know? Yes, Pinet or Askin group of tumors, right? It is most common in diaphysis of femur or diaphyseal region of the long bones, unlike osteosarcoma. We see the typical finding, the typical book finding of Ewing's sarcoma is lamellated or onion skin periosteal reaction, right? But we can also appreciate permeative or moth-eaten appearance. Soft tissue components are common, but soft tissue calcifications are not common. This is a very high yield point. Soft tissue calcifications are common in osteosarcomas, but these are not common at all in Ewing's sarcoma. Metastasis to bones are common in Ewing's sarcoma, most commonly in spine. Therefore, Ewing's sarcoma are more likely to be polyostotic and are likely to mets to bone rather than osteosarcoma, okay? And we discussed earlier, osteosarcomas have predilection to go to lungs in 80% of the cases. Ewing sarcoma can also go to lungs, but not as common as osteosarcoma. All right, so here we can see ill-defined lucency in the distal femur. Can you appreciate it? With a wide zone of transition and onion peel kind of periosteal reaction is also noted, which is lamellated kind of periosteal reaction typical for Ewing's sarcoma. This is MRI of the shoulder. Here we can appreciate heterogeneous intramedullary lesion. Okay, wait. Heterogeneous intramedullary lesion in the right humeral head and neck. It appears hyperintense on T2, which is shown here, and it is extending downwards to involve the rest of the medullary cavity of the humerus, right? And we can also appreciate there is destruction of the cortex as well. So this is a typical finding of Ewing's sarcoma. Now let's move on to chondrosarcoma. Chondrosarcoma, as opposed to Ewing's and osteosarcoma, usually occurs in older adults. Most common age affected by chondrosarcoma, 40 to 70 years of life. Okay, and most common sites are not long bones but proximal tubular bones because of more abundant cartilage. Distal femur is the most common site. This can be primary, this can be secondary. Primary ones are the ones that arise de novo, whereas secondary ones are the ones that arise from the osteochondromas or enchondromas. This can be intramedullary within the medulla or in the periphery at the end of osteochondromas. Metastasis to bone may be seen in chondrosarcoma, but never to lungs, almost never to lungs, okay? The risk factors are Paget's disease, multiple osteochondromas, Maffucci's disease. What is Maffucci's? Maffucci's is a disorder that is characterized by multiple enchondromas, cutaneous lesions, abnormalities of the blood vessels. All right, and also it is common Olier's disease in which there are multiple enchondromas. The typical finding in chondrosarcomas are rings and arcs, calcification. Why? Because it is cartilaginous matrix. Therefore, we see rings and arcs calcification. So here we can see the imaging of the hemipelvis. We can see mass that is extending from the left iliac blade with the characteristic popcorn calcification of the cartilaginous matrix, right? And here we can appreciate the chondrosarcoma in left olecranon process, where we can appreciate there is cortical destruction. This is again the difference between enchondroma, low-grade chondrosarcoma, and high-grade chondrosarcoma. Here is a lesion on X-ray. We can appreciate rings and arcs, calcifications in the proximal humerus, right? So this differential diagnosis would be enchondroma or low-grade chondrosarcoma. But on the CT, we see calcifications with subtle endosteal thinning of the cortical bone. Therefore, the final diagnosis established was low-grade chondrosarcoma, all right? Here you can see lobulated and ill-defined lytic lesion in the proximal humerus. We can appreciate calcifications. So it is a chondroid tumor, lytic lesion with cortical involvement, expansion. So this is high-grade chondrosarcoma. This is a very high yield slide, you guys. Chondrosarcoma versus enchondroma. Chondrosarcoma presents with pain, cortical destruction, scalloping of more than 2/3 of the cortex if the size is more than 5 centimeter and if the matrix is changing, okay? Initially it was rings and arcs, now it can be popcorn. So if the matrix is changing, so these 5 points favor chondrosarcoma over enchondroma. Chondrosarcomas, as we discussed earlier, can arise in osteochondromas. So these are secondary chondrosarcomas. The imaging findings of development of chondrosarcoma in pre-existing osteochondroma is given by mnemonic GLADPAST. G stands for growth after skeletal maturity, any new lucency, additional scintigraphic activity, cortical destruction, pain after puberty, soft tissue mass, or cartilaginous cap that is more than 1.5 centimeter. These are all findings that favor the chondrosarcoma formation in pre-existing osteochondroma. Okay, so now let's go core. We will be discussing few MCQs asked in the core examination. We just discussed the theory of a very high yield topic. Let's discuss some questions, okay? So a child with a history of a nighttime knee pain and swelling is evaluated in the ER. His X-ray is shown below. What disease does this likely represent? Your options are osteosarcoma, thalassemia, Paget's disease, Ewing's sarcoma. Okay, so first of all, whenever it is given, let's think of the history first, all right? Child, okay? Swelling in the knee and x-ray is given below, okay? Knee pain in a child around the knee, we discussed earlier, always think of osteosarcoma. So now this is the x-ray finding. What kind of periosteal reaction do you see? This is sunburst pattern of periosteal reaction, which is perpendicular to the surface of the bone. There is cortical destruction. There's new bone formation, right? And there is a very wide zone of transition. So these are all, and the lesion is located in the metaphyseal region. So these are all findings suggestive of osteosarcoma. Why not thalassemia? In thalassemia, the finding is here on end appearance, can appear like this, but not shown in the long bones, normally shown on the skull. And there is never cortical destruction in thalassemia. Okay, Paget's disease, there is thickening of the bone, there is remodeling of the bone. Ewing's sarcoma, never in metaphyseal region, almost always shown in core exams in diaphyseal region. Okay, so based on this image, what is your most likely diagnosis? Chondrosarcoma, telangiectatic osteosarcoma, lymphoma of bone, or primary ABC. First of all, where is the lesion located? It is located in metaphyseal region, right? Located in metaphyseal region. Is there cortical destruction? Yes. Does the lesion has wide zone of transition or narrow zone of transition? It has a very wide zone of transition. And do you see soft tissue calcification? Yes, we see soft tissue calcification as well, right? And there is soft tissue swelling. So, ill-defined lesion with periosteal reaction in the metaphyseal region with wide zone of transition, soft tissue calcification, most likely it is telangiectatic osteosarcoma. Why not chondrosarcoma? Because chondrosarcoma is expansile lesion, soft tissue calcification, not that common. Why not primary ABC? Primary ABC does not cause cortical destruction. No soft tissue components, calcifications are seen in primary ABC. All right. So the answer is telangiectatic osteosarcoma. All right, next question. Humoral radiograph of a 12-year-old male with Ewing sarcoma is given. Which of the following aggressive features is not seen in this image? Codman's triangle. Do you see Codman's triangle? Yes. There is lifting of the periosteum. Permeative appearance? Yes. There is permeative pattern of cortical destruction here. Soft tissue mass? Yes, soft tissue mass is present. Speculated periosteal reaction. Speculated periosteal reaction has to be perpendicular to the surface of the bone. Do you see anything as such? No, right? Periosteal reaction in this case would be, it is interrupted and it is multi-layered onion skin type of pattern, right? With Codman's triangle. It is not periosteal reaction of speculated pattern. And wide zone of transition. Of course, there is wide zone of transition and it is associated with soft tissue mass that is extending out of the bone, which is why the periosteal reaction is interrupted. So, which of the following aggressive features is not seen in this image? Speculated periosteal reaction. All right, next question. A 12-year-old boy has a lesion detected within his femur. Which of the following would most favor osteosarcoma over Ewing sarcoma? 12-year-old boy, right? A child can have osteosarcoma or Ewing sarcoma, both can be present in the femur, but which would favor osteosarcoma? Absence of any bony matrix. Can osteosarcoma not have bony matrix? Yes. It can have chondroid matrix, fibrous matrix, anything, like we discussed earlier, okay? Lamellated periosteal reaction. It can be present in either osteosarcoma or Ewing sarcoma. However, more characteristic of Ewing sarcoma can be also present in osteosarcoma. Metaphyseal location. Osteosarcoma is present in metaphyseal location, Ewing sarcoma in diaphyseal location. Pathologic fracture can present in both. Permeative pattern of both bone destruction can be present in both. So the correct answer is metaphyseal location, because Ewing sarcomas, they tend to occur in the diaphysis and osteosarcomas near metaphysis, but there can be a large amount of overlap between these two as well, okay? Next question. X-ray reveals a lucent proximal femoral medullary lesion containing rings and arcs calcification in keeping with a chondroid matrix. Which of the following would not favor chondrosarcoma over enchondroma? Read the question very carefully. X-ray reveals a lucent proximal femoral medullary lesion containing rings and arcs. Rings and arcs should ring the bell in your head of whether it is in chondroma or chondrosarcoma. Okay, rings and arc calcification is typical of chondroid matrix. In keeping with the chondroid matrix, which of the following would not favor chondrosarcoma but rather would favor in chondroma? Do you remember a very high yield slide that we discussed? Industrial scalloping involving more than two-thirds of cortical thickness. Yes, it favors chondrosarcoma. Increased uptake in bone scan favors chondrosarcoma. Pain favors chondrosarcoma. Size more than 5 centimeter favors chondrosarcoma. But young adults, young in chondromas may be seen in young adults, but chondrosarcomas seen in 40 to 70 years of life, never in young adults, right? In chondromas commonly seen in young adults, chondrosarcomas in middle-aged patients. So the answer is E, young adult. So that was the uh, end of our lecture today. If you want one-to-one radiology tutorials, please contact me at jessicacorella@gmail.com. Thank you.